Hi everyone, and welcome to this video on the pharmacology of chemical mediators. In this video, we're going to focus more on the local chemical mediators. So that's going to be the paracrine and the autocrine chemical mediators that are used in the body, and specifically how they may induce disorders or diseases or conditions that we need to tackle using pharmacological agents. So that's what we're going to really focus on today, and there's 5 different chemical mediators we're going to look at and the drugs that can kind of be utilized in that setting. So let's first get a definition of what a chemical mediator is. So in the body, we've got trillions, 30 trillion cells. They need to communicate between each other. Now we've got one system, the nervous system, that is specific, it's localized, it's fast, it goes on and off very quickly. But we can also utilize chemicals as the signaling molecules. Now they are generally released into the area, which can sometimes be taken into the blood, and that would be referred to as hormones, and they would be more so endocrinal in nature. But for today, we're going to focus locally, so we're going to look more autocrine and paracrine, which means these chemicals are released into the microenvironment to cause an effect, to cause a change in the physiology within that environment that's secreted from particular cells. Now, the ones that we're going to focus on for today is going to be histamines, prostaglandins, leukotrienes, cytokines, and nitrates. So this list isn't exhaustive, but these are probably the most common that you'll encounter in your pharmacological texts. So these are the local chemical mediators that we can use medications for to try to tackle particular conditions. So let's start over here with histamine. Histamine as a chemical mediator is an amine, which means it's an amino acid. It's derived from histidine. Now, it can be found everywhere in the body. So there's no real region in the body where you won't find histamine, but it is concentrated in a few areas. And these areas are the importance of today, what we're going to focus on, because this is where the conditions come about that we need to look at. So they are concentrated from particular cells called mast cells. So mast cells are very good cells at producing histamine, and they will induce things like inflammation and allergy reactions. So the mast cells are strategically located in the body where you're going to encounter the outside world. So you'll find a lot of mast cells under the skin, in your respiratory tract, and also in your gastrointestinal tract. So mast cells have already packaged up the histamines, and that's inside granules. And so when mast cells get annoyed by allergens or certain injuries, they will release their histamine. Histamine is then flooded into the local environment where they can then bind to receptors. Now, histamine receptors, there's 4 subtypes of histamine receptors in the body. Now, when we refer to allergies, they're probably more focused on H1 receptors, and that can be in the local smooth muscle. So what you're likely to see when your mast cells release histamine into the area when it's encountered an allergen, let's say pollen in the upper respiratory tract, it's going to induce smooth muscle contraction, and it's going to cause blood vessel leakage. And so this is the symptoms that you're going to start to see. You'll start to see a runny nose, runny eyes, itchiness. That's activating nerves, making them feel itchy. So this is the typical allergy responses that you will see. So the mast cells are probably the most common. They will be very quick in their releasing of histamines when they encounter injury or allergens. And they, as I said, probably focus more on the H1 receptors, mostly affecting smooth muscle. So there's certain drugs that we can use to counter histamines, and that's obviously going to be referred to as antihistamines. Some of the most common that utilize H1 in their blocking receptors is fexofenadine and loratadine. These are what we call generation 2 antihistamines. So why we've kind of gone through the generations? Well, another area of concentration of histamine is in your central nervous system. In your central nervous system, neurons actually use histamines as neurotransmitters. And one of the functions that they use in the brain for histamine is wakefulness. And so it keeps us awake during the day. But in the first generation antihistamines that we might have been using for allergies, these particular antihistamines would be very lipid soluble, and they'd cross the blood-brain barrier. They would bind to receptors that are associated with neurons, and they would actually turn off that wakefulness, and they would induce drowsiness. And so some of the problem with the first generation antihistamines were they induced a lot of drowsiness and made the person very sleepy. Now, that would be considered a side effect, but sometimes people will utilize this as actual indication. So sometimes antihistamines, the first generations, can be used as a hypnotic to help people sleep. And so antihistamines can be used in that regard as well, because the central nervous system does have histamine associated with it. Another location where you'll see lots of histamines is in the stomach. So in the stomach, we have a particular type of neuroendocrine cells called enterochromaffin cells, and they release histamines in response to food coming into the stomach or acetylcholine, which is coming from the vagus nerve. They release histamine, which then binds to their neighbouring parietal cells that release acid, and that's important for digestion. But in certain cases where people may have stomach ulcers or they may have reflux, you can use antihistamines, particularly on the H2 receptor, because that's the receptor on the parietal cell, and that will, as an antihistamine, such as cimetidine, that can block that effect, the histamine effect on the parietal cell, and they're going to release less acid, therefore taking the pressure off that ulcer or that reflux. So that's some of the examples of how we can approach using histamines, or specifically antihistamines. The next mediator comes not as an amino acid, it's as a fatty acid, and this group is called iconosides. The reason why they're called icono, it means 20. So this group of chemical mediators have 20 fatty, polyunsaturated chain of molecules associated with it. Now they come from the membranes of the cells that produce these chemical mediators. Now, there's different pathways that these iconosides go down. The most common are the prostaglandins, and they're associated commonly with inflammation. But we also have leukotrienes, and we can also have thromboxane, which is associated with platelet aggregation. So these, all different pathways are associated with these iconosides. So the prostaglandins, the thromboxanes, the leukotrienes, which at least these two I'm going to go through now. But the way that they work is dependent on what's happening in the body. So for this one, we're going to focus on inflammation. So certain cells that are associated with inflammation, like mast cells and dendritic cells, they will start to activate enzymes on their membranes once they've been injured or annoyed. And what they will do with their membrane, specifically the phospholipids, they'll activate an enzyme called a phospholipase A2 enzyme. And that will convert the phospholipid into what we call arachidonic acid. Once that's been activated, we then go down this pathway, which is going to use another enzyme called cyclooxygenase. For inflammation, the most common subtype of this cyclooxygenase is what we call 2, cyclooxygenase 2. There's two isomers of cyclooxygenase. There's a 1 and there's a 2. The 1 is more associated with physiological activities in the body using prostaglandins, such as uterine contractions, such as producing mucus in the stomach or regulating blood flow in the kidneys. So that's normal physiology that's always happening in regions of the body that use prostaglandins but are associated with a physiological response. What we're doing here is looking at a more pathological response, being in the case of inflammation. So these cells are now generating arachidonic acid with the use of cyclooxygenase 2 to produce prostaglandins. What the prostaglandins will do is work in that local environment to start to do what we would expect to see in inflammation. We would start to see vasodilation. We would see increased vascular permeability. And we would see pain. So this is what these prostaglandins are doing in that local region from the COX-2 enzyme, from these cells that we spoke about, such as macrophages. So vasodilation brings more blood to the area. Vascular permeability makes it more leaky, so you start to get swelling. And then pain sensitization, you're starting to get pain, which is not something pleasant. So here is where we bring the drugs in. Now, the most common drug that we would know is NSAIDs, so non-steroid anti-inflammatories. Now, these are a whole group, and there's a ton that I don't want to go through, but some of the most common ones would be ibuprofen, celecoxib, which is more a selective 2 COX inhibitor, and also diclofenac, which is like Voltaren, which kind of sits in the middle. So these would be the NSAIDs that would be associated with blocking more so COX-2 to downplay these effects in inflammatory responses. We can also have the SAIDs, which is the steroid anti-inflammatories, which are more to do with, say, cortisone, so hydrocortisone as an example. And now, because they are steroid, they are fatty, they will actually not block the enzyme, they will stop the genes expression to make the enzyme. So they will stop these enzymes being produced, unlike the NSAIDs that block the enzymes working. So that's how those steroid anti-inflammatories work, a little bit different than the non-steroid anti-inflammatories. Now we're going to go down a different pathway here. We're going to now look at something more associated with the respiratory system. So the membrane here are going to be cells in the respiratory tract. Some of the good examples here that would be used in this pathway would be mast cells and eosinophils, which are in the airways. They would be reacting again to injury or allergens, but what they're going to do is they will generate their membrane phospholipids, turn on the enzyme, make the arachidonic acid, but instead of going down this pathway, they're going to go down another pathway called lipooxygenase 5. So they're going to activate this enzyme, which then generates a different chemical mediator called leukotriene. The leukotrienes do similar things to what we saw over with the prostaglandins, but they're going to be more contracting smooth muscle in the bronchioles. So you're going to see bronchoconstriction. We're going to see increased mucus production. And we're going to see inflammation. Now, all of this is going to be what we see with asthma. So we're going to start to see the bronchioles close in, so it's going to be hard to move air. We're going to get wheezing, we're going to get coughing, we're going to get chest tightness. So these are things that will be associated with this kind of allergen response that we can sometimes see in a hyper-responsive or reactive airway. And that's driven by leukotriene as an example. So we want to counter this, we want to stop this, so we can use certain leukotriene modifying agents. Some of these agents can target the enzyme itself, so we can actually have certain medications that stop the lipooxygenase 5 working, and that would be an example, xylulin, or we could use leukotriene receptor blockers such as montelukast. In any case, they would try to stop this response happening in a hyper-responsive airway. So these drugs, unlike the asthma relievers like the beta-2 agonists, salbutamol, or the antimuscarinics, these are more prophylactic, so they're used as preventers. So these drugs could be used orally to prevent an asthma attack even starting. And so they would be possibly used in cases where the person may think it's likely that they could encounter an allergen to prevent that response even beginning. So that's the leukotrienes. Now coming across to the cytokines. The cytokines are associated, well, cyto means cell, kines means activator. These are chemical mediators that are associated with the immune system more so, and they're generally released from immune cells. There are over 100 in number, so we're not going to go through all of them, but they are more protein in base in terms of their chemical structure. They are subdivided into 5 groups. And these 5 groups can be based more so on what they do. So we have interleukins, which was once thought, inter means between, leukins means white blood cells. So they were once thought to be cytokines that would be communicating with white blood cells, but that's not always the case. There are plenty of cytokines that are released from other cells or from white blood cells that go to non-white blood cells. Then we have interferons, which sounds like interfere. And so these are chemical mediators or cytokines that are released from cells that have been infected by viruses to be released into the local environment to tell the local cells that you're likely to encounter a virus, be prepared, and look out to stop the viruses coming in to infect you. The chemokines, these are cytokines that are used to help with the chemotaxis. So this is the way that white blood cells move to an area of injury or inflammation. So what these cytokines would do is would help white blood cells migrate out of blood vessels and go into the tissue and migrate to an area of injury or infection. Then we have colony stimulating factors. So these would be cytokines that could be released from white blood cells that will go to bone marrow and increase the proliferation and differentiation of certain cells within the bone marrow to make certain subtypes of white blood cells. And then finally we have tumor necrosis factor, and these were once thought to be associated with cytokines that would instruct the white blood cells to go to tumours, to destroy them, to kill them, to stop cancers propagating and spreading. So these are the kind of subtypes of cytokines. Now, from a pharmacology standpoint, we could utilise some of these to help with certain conditions. So when we look at interferons, for instance, they are almost seen as antiviral particles. And so we could look at certain viruses, such as hepatitis. So in some cases where people are suffering from hepatitis, these interferons can be used to treat those particular viral infections. Other ones would be herpes or certain subtypes of multiple sclerosis. Another example of pharmacological agents that use cytokines would be monoclonal antibodies. So these antibodies would target specific tumor necrosis factor subtypes, and that could be in conditions like autoimmune conditions like rheumatoid arthritis or Crohn's disease, where these particular cytokines could be instructing the immune system to be kind of too over the top and causing injury and damage to those neighbouring structures. And we can use monoclonal antibodies to block the cytokines or block the receptor for them to work. We could also use monoclonal antibodies to help instruct the immune system to help kill off tumour cells as examples. So that is the cytokines. Finishing off with the nitrates. So this is another subgroup of chemical mediators. Unlike the others, this one is utilising a gas, a free radical gas. Now, where it's usually produced in the body is the endothelial cells. So this is the lining of the blood vessels. So when the receptor is activated on an endothelial cell, such as from acetylcholine, it can start a process beginning. The first step is to release intracellular calcium, so calcium levels start to increase within the endothelial cell. This leads to the activation of an enzyme, being nitric oxide synthase, which grabs a hold of amino acid arginine with oxygen to produce the nitric oxide. The nitric oxide then migrates outside or through the endothelium into the underlying smooth muscle of the blood vessel, and that would activate another enzyme system, in this case guanyl cyclase, and this activates a intracellular second messenger system called cyclic GMP. The activation of cyclic GMP then tells the actin and the myosin within the smooth muscle to kind of relax, and we see relaxation of the smooth muscle and then dilatation of that blood vessel. And this is important for the regulation of blood pressure and blood flow within the body physiologically. But we could utilize this in a pharmacological way in certain conditions. Now, the first two, the most common ones in terms of utilizing this as a clinical indication, is for angina or in cases of potential heart attack. So the first drug is GTN, or glycerol trinitrate, and what this basically does, it's usually administered under the tongue as a spray or a tablet, dissolves and quickly makes its way into the blood. It would then utilize this system to relax smooth muscles. In many cases, it would work in the venous system, and so it would reduce the amount of blood coming back to the heart, and it would take the workload off the heart, which is important because in angina, the heart is working too hard and running out of oxygen, and that's why we get in the pain. So it will reduce the preload going to the heart, therefore the workload, but the drug would also go in the downstream smaller arterioles to dilate those, and that would reduce the afterload, the pressure back onto the heart, also reducing workload. These drugs, or GTN at least, can also go to the coronary arteries and dilate those to bring more blood into the heart muscle. So it's doing a combination of reducing workload of the heart and increasing blood supply or oxygen supply to the heart muscle. Now that's usually used in acute setting where a person who has angina has an angina attack, so they have a bout of chest pain. Through exertion, they take GTN under the tongue and hopefully the angina symptoms resolve. But where they may have more chronic angina that they need to take these medications more long term, there's kind of longer acting drugs, in this case isomorbid mononitrate. Now this would be taken orally, and this would be kind of keeping those levels higher for longer periods of time, unlike GTN, which is kind of a quick acute fix. So this could be taken by patients every day during the waking hours to take that kind of strain off the heart. But then we can look at another drug which is usually used in critical care settings such as ICU, and this would be nitroprusside, and this is probably used as IV medications in cases of very high blood pressure. We need to bring it down, and so through the same mechanism we just get huge dilatation throughout the body and bringing the blood pressure right down, or in cases of extreme heart failure where you need to take a lot of pressure off the heart to stop it essentially given up, and that could be also a drug used in that acute setting. A final interesting one that still uses a nitrate as its mechanism is Viagra. So the generic name is the sildenafil, and the way it works is a slightly different mechanism. There is an enzyme in the smooth muscle called phosphodiesterase 5 that kind of turns off the cyclic GMP. So this drug, sildenafil, kind of blocks that phosphodiesterase, therefore leading to a cyclic GMP to remain high in the smooth muscle and the smooth muscle to remain relaxed. Now, this would be in cases more so erectile dysfunction, so that smooth muscle dilatation would be more associated with the penis. That leads to more blood flow staying in the penis and therefore the erection to remain. And that's how that mechanism is utilized in that particular clinical indication, which is still under the banner of nitrates. So that's it. That's the local chemical mediators. That's the most common ones. And that's a list of pharmacological agents that we can utilize in these disease or disorder settings. We've looked at histamines. We've looked at the two types of eicosanoids, being prostaglandins and leukotrienes. We've quickly looked at the cytokines, and then we've finished off the nitrates. Hopefully that's helped. Thank you, and we'll see you next time.
Hi everyone, Dr. Mike here. If you enjoyed this video, please hit like and subscribe. We've got hundreds of others just like this. If you want to contact us, please do so on social media. We are on Instagram, Twitter, and TikTok at Dr. Mike Todorovic, at DrMiketodorovic. Speak to you soon.